So we're going to go ahead and get started on chapter 44, thyroid and anti-thyroid drugs. So on page 524 in your text, let's talk about these key points briefly. The thyroid gland secretes the hormones thyroxine and triethioadrenaline. I always butcher that too. And they help control metabolism. So when we talked about glucose, we talked about our body needs energy in order to function, in order to, carry on with our daily lives. So the process of our body breaking down those molecules for energy, that is metabolism. So all of that stuff is happening, but our body has a gland and it controls that metabolism and controls what's going on, and that is the thyroid gland, okay? So the thyroid gland secretes hormones and they help to control metabolism, which is the breaking down. So that's why we're doing it together with chapter 42, because all of these processes are kind of happening at the same time, okay? The process is controlled by the pituitary gland when it secretes a thyroid stimulating hormone. So I'll probably share a video much like I did for glucose, but what happens is the pituitary gland releases a hormone, and it's called the thyroid stimulating hormone. And it tells the thyroid what it needs to produce in order to get that metabolism of the body going. So you can have a pituitary issue in which you're not releasing that stimulating hormone, or you can have an issue of the thyroid in which you're either overproducing or underproducing. So we're talking specifically about the thyroid today, okay? So if your body produces too much, there's diseases. Okay, if there's too many if there's too many thyroid hormones, that is hyperthyroidism. If there's too few, it's hypothyroidism, okay? And there's disease processes with each, with the highs and the lows. So we want homeostasis. We want to have a beautiful little perfect level, and our metabolism is rocking on just like it's supposed to. Everything is beautiful. But when it gets out of whack, we have diseases and we have issues that go on. And if it's our regulator, then stuff in our body is no longer regulated. That makes sense? Okay, so the signs and symptoms can be found on page 520. Those are the signs and symptoms of thyroid dysfunction. So your thyroid not only affects your metabolism, it affects your cardiovascular system, it affects your central nervous system, it affects your skin, your ovaries, if you have them, and your testicles, depending on if you're a male or a female. So if it is underactive, so if it's where it's supposed to be, then our sexual function is normal. Not necessarily our production of those sex hormones is normal, I should say. Our skin is normal per se. Our metabolism, we're able to regulate all of those natural body processes. When something is out of whack, all that stuff is messed up. So if it's underactive, signs and symptoms of hypothyroidism, intolerance to cold, low body temperature, weight gain, low heart rate, which is bradycardia, hypotension, lethargy, sleepiness. So think if our thyroid has to do with metabolism. Think about metabolism is our energy. It is the thing that keeps us going and it keeps us fueled. When it's below par, when it's not up to where it should be, it makes sense that we're a little more sluggish, right? It makes sense. Think about your people who are like burning fat and their metabolism is super high. They usually put off a higher degree of heat because they're just working internally. Their skin is usually, if they have hypothyroidism, is pale, cool, dry. They usually have heavy menstrual cycles. They sometimes have difficulty conceiving. And for males, they have a lower sperm count. Okay. Those are signs and symptoms of hypothyroidism. Hyperthyroidism, think about revved up, right? Our metabolism is like we cannot slow down. We have an increased appetite, elevated body temperature. Our body is just burning, even though we're not trying to burn. So these patients are usually underweight. Their heart rates are higher, tachycardia, moderate hypertension, nervousness, anxiety, insomnia, tremors. Remember, they're revved up, right? Flushed, warm skin, thinning hair, and they often have a goiter for that overproduction of a goiter is it's kind of like a growth on your thyroid from it's just producing. It's enlarged basically. And then they often do not, their menstrual cycle is usually diminished or they don't have one, at all. So it's important that you understand those differences. So that's that. So our drugs that we're given, if they have hypothyroidism, we're going to give thyroid drugs because we want to give them what they need. If they're if they have hyperthyroidism, then we're giving drugs to slow that down. They're called anti-thyroid drugs. That makes sense, right? All right. So basically everything I told you is going to be drug out in these following slides, okay? But I'm still going to go over it. So the thyroid gland, we said it secreted hormones. Pituitary gland tells it to, and the hormones that the thyroid secretes are T3 and T4. So as nurses, there are lab levels. We're not just basing our stuff on these signs and symptoms of hypo and hyperthyroidism. I've been trying to blame my weight problems on hypothyroidism for years, but I'm yet to have any blood work to support my theory. So here we are. It's not just about having all of the signs and symptoms. That T3 and T4 in your body will be off, okay? This process is controlled by the pituitary gland when it secretes the thyroid stimulating hormone. So that is also a lab level, TSH, thyroid stimulating hormone. So when your patient has labs done for a thyroid panel, they have TSH, T3, and T4 generally, okay? All right. So the condition associated with hypothyroidism is Hashimoto's thyroiditis. That's probably my favorite word in all of nursing. I don't know why. I just think it's fun. So if they have Hashimoto's thyroiditis, when a person presents with these problems, it's basically everything that I just told you in the hypothyroidism section, okay? But it's a disease process. It's not just a few of those signs and symptoms. Graves' disease is an example of a condition that causes hyperthyroidism. So again, the stuff whenever we talked about hyperthyroidism, presenting problems, increased metabolism, weight loss, intolerance to heat, that chart I told you, I would definitely want y'all to be familiar with it, okay? So euthyroid is normal function. Like everything is good. The goiter is that enlargement of the thyroid gland, swelling in the front of the neck, and it's usually caused by that overproduction. People can have it with, I'm not going to get into all that patho. Sometimes when they have hypothyroidism, their pituitary gland is sending it's stimulating and it's saying produce, but it's not producing. Sometimes when those signals are mixed up, you can still have a goiter, but most often it's with hyperthyroidism, okay? And then thyrotoxicosis is severe hyperthyroidism, and so it's to the extreme, okay? High fever, extreme tachycardia, altered mental state. It's beyond just that hyperthyroidism. It's also known as a thyroid storm. It is like complete explosion of thyroid hormones, okay? I have told you all this, right? Y'all feel okay with me going on? So when we're using these drugs, when we're using thyroid hormones, we're going to use them for goiters. You know, when people have goiters, we're going to decrease the size by giving these hormones. When they have nodules, these medications may be given. When they have thyroiditis, when, you know, lymphocytic is when stuff is eating those cells, or when they have thyroid cancer, these drugs may be used. The most common adverse reactions are on the other end of the spectrum. So a sign of overdose and hyperthyroidism as titration is being attempted. So we're monitoring these labs very, very closely. Remember the T3, T4, we're monitoring those labs. So when we put a patient on a thyroid medication, we might put them on too much, right? So then we're going to need to titrate those medications. We're going to get some more labs, and then we're going to lower their dose. Well, here we go. You know, the body doesn't work always how it's supposed to. So those labs are going to be an ongoing thing, okay? So when your patient is saying, I was feeling really, really good, but now my heart rate just seems a little bit off. I keep feeling it. I keep feeling it flutter in my chest, and, you know, it seems like it's beating a lot faster than normal. You need to pay attention to those things. So my father-in-law has, he has thyroid problems, and he didn't really, I hate to say he didn't take care of himself. Not a person that went to the doctor, I guess, regularly. Didn't have routine blood work. Didn't have, you know, all of those things where they would check this every couple of years. And he went into SVT. So he called one day, and his heart rate, that's that supraventricular tachycardia, and his heart rate, by the time he got to the hospital, his heart rate was 230. Well, the root of all that was a thyroid problem. So he's on thyroid medications, really doesn't have anything. They did a stress test. They did, you know, all this whole battery of things. And at the end of the day, his thyroid was the cause of that extremely elevated heart rate. So it can definitely have an effect on, you know, other body systems. We're not going to give thyroid hormones to patients with a known hypersensitivity to the drug. We're not going to give them to patients with the thyroid storm. And we're going to use them really cautious if somebody already has a cardiac disease. You know, if they already have cardiac disease, knowing that these medications can affect the heart rate and whatnot, we're going to use them very, very cautiously. They do interact with some oral hypoglycemics. Whoops. Some anticoagulants. And beta blockers and digoxin. So there's oftentimes, that's why a lot of these medications have to, so think about your patients who have hypothyroidism. We said they're generally overweight, okay? So they're already overweight, which puts them at risk for diabetes, right? And high blood pressure. So these medications that we have them on for this could potentially decrease the effect of their beta blocker, and it could potentially increase their risk for hypoglycemia. So that's where all these little tight controls of all these medications, that's where these drug-drug interactions come in. So they might be taking their medications exactly as prescribed, and we still might see some issues, you know, with all of those different types of medications. We haven't talked about SSRIs yet, or antidepressants, but they can interfere with those medications as well. All right, so your job, if you know what the thyroid does, then you know what you're looking for as far as assessing these patients, right? Vital signs, particularly what? Y'all are muted. Y'all can unmute because we're going to talk about this part. Everybody can unmute unless your house is like crazy loud.
Heart rate.
Heart rate, yes. Blood pressure as well, because you know, that's going to often be decreased if they have hypothyroidism. What it was one other thing that we specifically mentioned?
Glucose?
Not necessarily.
Their weight?
Their weight, yes. And there's one other one. Their temp. Because if they're hypoglycemic, they often have a lower baseline temp. If they're hyperglycemic, then they often have a higher baseline temp. So physical assessment. So what did we say based on those signs and symptoms of thyroid dysfunction? What are we looking at on their skin? What are we checking it out for?
Temperature?
Temperature. So feeling it, does it feel, so that's one of them. There's another one that was specific on there. Y'all can look at that chart. I know you don't know it yet.
Dryness? Or
Dryness, yes. Dryness and color. So a lot of times if they're revved up, hyperthyroidism, they're going to be flushed. Hypo, they're going to be a little more pale. And also that temperature, the dryness. Talked about vital signs. So this ineffective protection, when your patients have one of the treatments for thyroid cancer is, let's see, I'm trying to find this radioactive iodine. It's used it's on page 525. It's used in selected cases of thyroid cancer. And it's also used for extreme hyperthyroidism. It can cause bone marrow depression, nausea, vomiting, and tachycardia. So right here where it says ineffective protection related to urinary elimination of radioactive isotopes, it's almost like radiation. So when your patient is on radiation and they urinate, all of that is radioactive. It makes me want to sing that song, radioactive. But that elimination could be harmful to others because it has that activated iodine. It's because it's radioactive. So that's what that's talking about, ineffective protection. Risk for ineffective self-health management related to consistent dosing or titrating dosages. So if they're not showing up for their labs, their drugs may or may not be adequately controlling their, their disease processes. Risk for infection, especially if they're on that radioactive iodide because it causes bone marrow suppression. All right. So we want to support our patients' needs always. We want them to be compliant always. Thyroid hormones, when we're administering these medications, they're administered once daily, early in the morning, and before breakfast. Because we saw that they had some drug-drug interactions there, right? So we want to give them by themselves, if at all possible. We want to monitor patients for any adverse reactions and document them well to provide information for correct dosing. So like I said, if your patient's saying, oh, I was feeling some palpitations the other night when I went to sleep, but it was no big deal, we want to make note of all that stuff. Because, in a couple days when it is a big deal, we will have kind of seen that coming. Closely monitor patients with diabetes during hormone replacement therapy for signs of hyperglycemia and notify the primary healthcare provider. Remember, we said there can be some drug-drug interactions that go on there. So we especially want to monitor their sugar. And we want to observe our patients who have cardiovascular disease. And I've already told you guys why, right? Because not only can the thyroid affect those things, it can also, those drugs that we're giving can also cause a drug-drug adverse interaction there. So when someone has their thyroid removed, let's say you have thyroid cancer or it's like off the charts overactive and they cannot chill it out. When they have that thyroid removed, you have to live with thyroid, you have to have some thyroid hormones. So we're going to give them hormones, thyroid hormones by mouth. They're not temporary. You always need your metabolism. You always need, for your thyroid to work. So they need to understand that these medications are not just for the short term because you just had surgery. If we take your thyroid or we take a big honking chunk of your thyroid and you're not producing T3 and T4 like you're supposed to, you're going to be on these drugs forever. That makes sense? And we've already talked about taking it in the morning before breakfast unless advised otherwise. Weigh yourself weekly and report any significant weight gain or loss. So we don't want to be my father-in-law, right? We don't want to go into SVT before we realize that we have a thyroid issue. We want to catch that stuff as early as we can. So if our patient lost 7 pounds or gained 7 pounds in a matter of 10 days, that's going to be a red flag for us. But somebody asked,
identified and reported to the primary healthcare provider.
I didn't hear you, Essence. I'm sorry.
Oh, I didn't even know I was off mute. I'm sitting over here talking to myself. I was reading over the PowerPoint. I'm so sorry.
Let's see. So periodic thyroid function tests. So we're going to encourage them to show up for those appointments. We want to recognize those adverse reactions. We want our patient to verbalize and understand their treatment. All of this we already know. So anti-thyroid drugs. So let's look at our chart real quick. So thyroid hormones, if you look on page 525, those top ones, that T4, T3, T3 and 4, those are going to be given, if you want to make a note, those are going to be given when we have low thyroid hormones, when we have hypothyroidism. Does that make sense? In hypo, we're not producing as much T3 or T4, so we are giving it externally. Or if your patient, I don't want to confuse y'all, but I want y'all to think about this, or if your patient had hyperthyroidism and we took their thyroid, then essentially they now have hypo. Does that make sense? They have low thyroid because we took their thyroid. So they might be on these drugs as well. So their primary diagnosis could be hyperthyroidism, but they had a thyroidectomy, therefore they need those hormones. Does that make sense? Okay, so the top ones are for when we have low thyroid hormone. Those other ones, the anti-thyroid preparations, that's what we're about to talk about now. Those are for when we have high hormones. So they are kind of like the blockers. They inhibit the manufacture of the thyroid. So this is before they had surgery. Like this is not everybody who has hyperthyroidism has to have surgery. This is our means of chilling that out. So if we can inhibit the manufacture of that T3 and T4, then we'll be bringing us back down to the normal range. Does that make sense? They're administered before surgery to temporarily return a patient to a euthyroid state. So they're often given. And then usually one of the main treatments, if your thyroid is just overproducing, they'll usually take a little piece of it. They'll do a partial thyroidectomy. So they're often used in conjunction with surgery. And then the radioactive isotope, I've already touched on that, accumulates in cells of the thyroid gland where destruction of thyroid cells occurs without damaging other cells throughout the body. So when patients take this, they take it and it's like radiation that goes inside of the thyroid, but it's in a pill form. Crazy, huh? So it goes inside of the thyroid and it kind of destroys it from the inside, but all of your other cells in your body are pretty much okay. for the most part. I mean, you have some adverse reactions, but that's its mechanism of action. All right. So this methimazole, and y'all know I stink at pronouncing stuff, propylthiouracil are used for the medical management of hyperthyroidism, like I just told y'all. The potassium iodide may be given orally or with the 2 drugs above to prepare for thyroid surgery. And then the radioactive iodide is used for treatment of hyperthyroidism and select cases of cancer. So their side effects are kind of vague, like with the generalized, just normal ones: hay fever, sore throat, skin rash, fever, and headache. They're kind of just some vague symptoms. But severe reactions would be agranulocytosis, exfoliative dermatitis, where the skin kind of starts flaking off, granulocytopenia, when all of your, those granulocytes that are supposed to be in your blood, when all of that starts to be suppressed. And then drug-induced hepatitis. So they could cause major issues for your liver. They could cause major issues within the circulatory, within your blood system. Okay. We talked about having some drug-drug interactions with oral anticoagulants already. Okay, so your job is going to be pretty much the same. Obtain a history of symptoms of hyperthyroidism before the patient starts therapy. So we need to have good documentation of what their normal life looks like before we add these other hormones, what their heart rate looks like, what their skin looks like. All of that stuff needs to be documented very well. If your patient has an iodine allergy, you sure as heck aren't going to give them iodine by mouth, right? So that needs to be documented well. You need to ask those questions. In regards to the adverse reactions that we talked about, you just need to ask those questions. Have you had increased bleeding? Have you had a lot of bruises? Do you have a sore throat? Like, ask your patients. Don't just be like, how you feeling? Oh, I feel good. No, go into those questions and ask them so that you can get an accurate depiction of what's going on. You need to know what that thyroid storm is. It can be found on page, I talked about it already, but there's a little box in the book that talks about a thyroid storm. It's a super, yeah, right on page 520, talks about the thyroid storm. So our patients on these thyroid and anti-thyroid drugs have a risk for ineffective therapeutic regimen management. They might not want to wake up early and take that medication. They have a risk for infection as related to those adverse reactions. They have a risk for impaired skin integrity, again, with those adverse reactions. We want them to have a good response to treatment. We want to address the things that they're experiencing, those adverse reactions. We don't want the full out thyroid storm to take place before we recognize that anything is wrong. We want to assess and come in early. We want to remember that goiter that we talked about. If there's hyperthyroidism and there's an overproduction and there's enlargement of that goiter, enlargement of that thyroid gland, it can cause problems with their swallowing. So that's something that we need to take into consideration as nurses. We really need to pay attention to those cardiac symptoms. So be sure to, pay attention to that. Suggest posting a note in the bathroom to remind patients that the first dose is due immediately after rising. Whatever you can do. So my husband does not have thyroid problems, But remember I told you he went from being totally healthy to taking those medications? It was a struggle. Like, we tried so many different things. Like, we put it by his toothbrush, but he didn't really want to take it till he ate because it made him feel sick. And, you know, so we tried all of these different, I got him like a pawpaw medication divider, and he forgot that in his truck or in his cargo trailer. And it was like, well, I'm like, oh, and finally it was like, okay, you're an adult, we're adults, we've got to figure out something that works so that you can take these medications every day. And until it became a habit, we had to set an alarm on his phone and we had to keep it in his glove box, you know, because that was, and if he was inside or no matter where he was, he'd have to go out to his truck because that was the most convenient thing for him. But your job as a nurse is to say, you know, what works for your patient, because once they've gone through the whole day and they haven't taken their thyroid medication, it's very hard to keep those levels where they need to be if you're skipping doses all over the place, right? Let's see. Monitor for signs of agranulocytosis. Monitor for signs of infection, particularly upper respiratory infection. Carefully document the affected areas. This is when they have problems with their skin. If they have that skin disorder that we talked about that could be caused, make sure that we're documenting what that rash looks like. How widespread is it? You know, is it a small area, a large area? Is it on just their torso? You know, be very specific in regards to what it looks like. None of these drugs, the dose doesn't need to be altered. Remember those vague signs that we talked about, sore throat. It kind of starts as a sore throat, but then it's fever and cough, you know, and it progresses. So we wanted them to know that these are the signs and symptoms that they're looking for. So like, just for example, not to confuse y'all, but whenever I had the coronavirus, I thought I had a sinus infection because I really didn't feel, this is before I knew y'all, I'm not infected. I really felt okay. I mean, I didn't feel okay. I felt rough, but I felt, you know, it was those vague symptoms. It was, you know, I had a little tickly cough. My nose was really stuffy. I had a headache and I was tired. Well, those are not abnormal symptoms, you know, if you have a cold. But the moment that I lost my taste and smell, those were red flags. So if your patients know, but if nobody had ever told me, like that those were anticipated signs and symptoms, you know, of the virus, like that was my red flag to say, okay, something's going on, something's wrong. Same way with your patients. If you say up front, if you get a sore throat while you're taking this medication, you need to call your doctor. That is more, they can pinpoint that, because on a normal day, you're not calling the doc every time you get a sore throat. Do y'all understand what I'm saying? So be a good educator for those specific kind of things so that your patients can take better care of themselves. Let's see. Excuse me. Okay, so for the radioactive iodine, there's some very specifics for that. You needed to follow the Department of Nuclear Medicine's directions regarding precautions to be taken. There's going to be different precautions as far as like where they urinate in their own bathroom. There's going to be very specifics in regards to getting rid of their waste and different stuff like that for the radioactive iodine. But y'all understand, think about that as far as like if there was a radioactive event. Did y'all learn about that in Ms. Lott's class? How you would treat those kind of things? No? Okay. Just know radiation is harmful. And so these people who are taking these medications, there's going to be very specific precautions in regards to them, okay? Thyroid hormone replacement therapy is necessary if hypothyroidism develops. So remember I told y'all that if they have hyperthyroidism and then they get their thyroid removed or they take that radioactive iodine, then we're going to be treating them for hypothyroidism. And then we want to schedule the necessary follow-ups and evaluations to take care of all that. At the end of the day, we want a therapeutic effect to be achieved. We don't want them to be anxious regarding this therapy. We want them to report those signs and symptoms to the healthcare provider. We want them to be compliant and demonstrate a good understanding of their medication. All right, I'm gonna ask these, and then we might play a quick little game of what's it called? Kahoot, or is that what it's called? Yeah, Kahoot. True or false? The thyroid gland secretes the hormone thyroxine, T4, and T3, which help control metabolism. True or false? Yes, Kelsey. True. Everybody agrees it's true. Yay. True or false? Hashimoto's thyroiditis is an example of a condition that causes hyperthyroidism. Good. False. So remember, I mean, if y'all remember things weirdly, I do. I already told y'all that. Remember, Miss Traylor really thought she had hypothyroidism? And that's her favorite word, is Hashimoto's thyroiditis. So those two go together, and hyper and Graves' disease go together, okay? That's kind of one of those things you'll need to remember for a long time. True or false? Graves' disease is an example of a condition that causes hyperthyroidism. Yay. All right, so that's it for that. Y'all feel pretty good about it, huh? It's pretty self-explanatory. I feel like that's probably one of the easiest chapters that we do. So let me leave that. Hey, y'all there? I don't know what happened. It just is gone on my laptop. Will it let anybody save the recording? Does it give y'all the option where it says stop recording, or is it grayed out?
I don't see it. I think if the PowerPoint was up and like we could take control, usually it has that button, maybe we could have stopped it, but I don't see that anymore.
I don't want y'all to hang all the way up. We probably won't do Kahoot. We'll probably just end class. But I have to show my my PowerPoint in the evening. And I hate to lose the whole recording if I can help it. So, but it won't let me back in. So, I guess I will send y'all. I'll try to find a little Kahoot that we can play. You know, either on your own or at the beginning of class to kind of review some of the information. I think this test should be pretty decent if you memorize all the insulin stuff, and the thyroid drugs are pretty easy, and knowing the difference between hypo and hyper, I think y'all are going to be okay. Y'all have any questions for me? I see where Brendan just raised his hand. I'm on my phone now, so it's hard for me to see everybody.
Sorry, I pushed the button wrong.
Okay. Yeah, I don't know why it won't let me save it, but I guess I'm not going to be able to. Let me try one more thing. I guess we're doing good if this is our first major technical difficulty and we're a couple weeks in, huh? Okay. I'll fight with that later. But I guess if y'all feel okay, then we can go ahead and end class. No questions at all. Feel pretty decent.
We're meeting on campus tomorrow.
Yes, we will be at the school tomorrow at 8. I'm pretty sure. Okay, so the classroom, we're gonna start out in the classroom that we took our tests in the MA classroom, and we may mosey over to the skills lab, depending on like if they're testing in there, because I don't want y'all to have to be super, super quiet because we're gonna be doing stuff and communicating. So if they're having class, then we'll be able to stay in there. But if they are testing, then we'll probably mosey over to the skills lab. So just go ahead and go on in, and I'll meet y'all in there. I'll probably be there at like I won't be late. You know, I'll be there at like 8:05. Got to grab some stuff out of my office, but I'll meet y'all in there, and hopefully we'll get everything squared away so we can try to check off after y'all's test on Monday. That's my goal. That's what I'm wanting to do. But I want to make sure y'all are good and comfortable. All right, no questions? All right, y'all have a good day.